Describe your process for triaging a waiting room full of patients following a major incident. What are your three immediate priorities?
This scenario demands rapid assessment, decisive action, and clear resource allocation. My process for triaging a waiting room full of patients following a major incident, such as a mass casualty event or multi-car accident, strictly follows established disaster and emergency protocols to maximize survival chances for the greatest number of people. Upon initial arrival, or when patients start pouring into the waiting room, my first immediate priority is scene safety and access. While the main incident site is managed by others, within my area, the emergency department or triage zone, I ensure clear pathways are established, unnecessary personnel are restricted, and adequate lighting and basic supplies are immediately accessible. This allows for swift patient movement and prevents further harm. My triage process begins immediately, utilizing a standardized system like START, simple triage, and rapid treatment. I quickly move through the waiting room, performing an assessment of respirations, perfusion, and mental status (RPM) for every individual in under 60 seconds. Patients are tagged with color-coded markers, red, yellow, green, black, indicating the severity and immediacy of their need for care. For example, a patient with spontaneous respirations over 30 per minute or immediate capillary refill time over 2 seconds will be tagged red immediate. My second immediate priority is identifying and stabilizing life threats, red tags. While green tags, minor injuries, can wait, and black tags, deceased/unsurvivable, receive comfort care, my immediate focus shifts to the red tags, those with critical, salvageable injuries like hemorrhagic shock or tension pneumothorax. I initiate basic, life-saving interventions immediately at the triage point, such as applying direct pressure to severe external bleeding or establishing an airway adjunct. This brief intervention is critical to buy them time before they can reach definitive care. Finally, my third immediate priority is resource allocation and communication. Once the initial triage is complete and red tags are stabilized and prioritized for transfer to the trauma base, I clearly communicate the total number of patients, the number in each triage category, and the types of injuries to the charge nurse and command center. This data is vital for them to allocate specialized staff, secure blood products, and prepare operating rooms. The process is continuous. As the situation evolves, resources are shifted, and patients are rapidly re-triaged if their condition changes, ensuring the ongoing flow of critical information and care.
You encounter an unresponsive patient in the hallway. Outline the steps you would immediately take for basic airway management.
If I encountered an unresponsive patient in the hallway, my first priority would be to ensure safety and establish whether the patient is breathing adequately. I would quickly check the surroundings to make sure there was no immediate danger to the patient or staff, then approach the patient and assess responsiveness by calling out to them and applying a gentle sternal rub. When there was no response, I would immediately call for help, activating the emergency response system and asking nearby staff to bring the resuscitation trolley and oxygen. I would then assess the airway and breathing simultaneously. I would position the patient flat on their back and open the airway using a head tilt chin lift technique unless there were signs of trauma, in which case I would use a jaw thrust. I would look for visible obstructions such as vomit, food, or secretions and clear them using suction if available. At the same time, I would check for normal breathing by looking for chest rise, listening for breath sounds, and feeling for airflow for no more than 10 seconds. If the patient was not breathing or breathing inadequately, I would begin basic life support immediately, starting with rescue breaths using a bag valve mask connected to oxygen while ensuring a good seal and correct head positioning. If I identified that the patient had a pulse but was not breathing effectively, I would continue ventilations while closely monitoring their airway and oxygen saturation. If there was no pulse, I would commence chest compressions without delay. In a similar situation on a medical ward, I found an elderly patient collapsed outside the bathroom. By rapidly opening the airway, suctioning secretions, and providing assisted ventilation until the resuscitation team arrived, we were able to stabilize the patient and restore effective breathing. The patient was later transferred to the high-dependency unit and recovered without neurological deficit. This reinforced for me how critical prompt airway management and calm, systematic action are in preventing deterioration and saving lives.
How do you apply a sepsis screening tool like NEWS or SIRS criteria in a fast-paced A&E setting, and what are the initial 6 actions you would delegate or perform?
In a fast-paced A&E environment, applying a sepsis screening tool needs to be rapid, structured, and integrated into routine assessment rather than treated as a separate task. When a patient presents with possible infection, I prioritize obtaining a full set of observations immediately on arrival, including respiratory rate, oxygen saturation, blood pressure, heart rate, temperature, and level of consciousness. These are entered straight into the electronic system, so the score is calculated in real time. I pay particular attention to trends, as a rising respiratory rate or new confusion often indicates deterioration before other parameters change. During a busy evening shift, I assessed a middle-aged patient who arrived with shortness of breath and fever. Although initially ambulatory, his respiratory rate was 28, oxygen saturations were 90% on air, and his blood pressure was borderline. The combined score triggered an urgent response, prompting me to escalate to the medical registrar without delay while continuing my assessment. At the same time, I focused on identifying red flags such as reduced urine output, mottled skin, and altered mental status, which supported the likelihood of sepsis. Once sepsis was suspected, I ensured the initial 6 actions were commenced within the first hour. I administered high-flow oxygen to optimize tissue perfusion and obtained blood cultures before antibiotics were started. I prepared and administered broad-spectrum intravenous antibiotics as prescribed, ensuring there was no delay due to access or documentation. I took a venous blood sample for lactate and other urgent investigations and closely monitored the result to assess severity. Intravenous fluids were commenced promptly using a wide-bore cannula, with careful monitoring of the patient's response, particularly blood pressure and urine output. I also inserted a urinary catheter to accurately measure output and reassess fluid balance. In this case, early recognition and coordinated action across the team led to stabilization within the first hour, and the patient was transferred to critical care for ongoing management. Working efficiently with screening tools in A&E allows me to identify sepsis early, prioritize care appropriately, and ensure life-saving interventions are delivered without delay.
Walk me through your primary and secondary assessment of a patient who has experienced significant blunt force trauma.
When assessing a patient who has sustained significant blunt force trauma, I approach the assessment in a structured and methodical way to identify and manage life-threatening injuries first, while continuously reassessing the patient's condition. On arrival, I begin with an immediate overview to gauge the mechanism of injury, as this often indicates the severity and potential complications, such as internal bleeding or spinal injury. My initial focus is on the primary assessment. I start by assessing and protecting the airway while assuming a cervical spine injury until proven otherwise. I manually stabilize the neck and check that the airway is patent, looking for obstructions, facial injuries, or abnormal sounds. If needed, I provide airway support using adjuncts and oxygen. I then assess breathing by observing chest movement, checking respiratory rate, oxygen saturation, and auscultating the chest to identify asymmetry, reduced air entry, or signs of pneumothorax. Circulation follows immediately, where I assess pulse, blood pressure, skin color, and capillary refill, while checking for obvious external bleeding and controlling it promptly. 2 large-bore intravenous cannulas are established early, and blood samples are taken for urgent investigations. I also perform a rapid neurological check, assessing level of consciousness and pupil response before fully exposing the patient to identify hidden injuries while preventing hypothermia. Once the patient is stabilized, I move into the secondary assessment. This involves a detailed head-to-toe examination, taking a focused history if possible and documenting all findings carefully. I inspect and palpate the head and face for bruising or deformities, assess the chest and abdomen for tenderness or guarding, and examine the pelvis and limbs for instability, swelling, or reduced movement. I also reassess pain, review vital signs, and monitor trends closely. In a previous road traffic collision case involving a young adult, this structured approach allowed us to identify internal bleeding early despite minimal external signs. Prompt escalation and imaging led to rapid surgical intervention, and the patient made a good recovery. This reinforced the importance of a calm, systematic assessment in managing major trauma effectively.
A patient presents with 10 tenths pain from a fracture but has no 4 access. Discuss your pain management strategy and medication choice.
When a patient presents with severe pain from a fracture and has no intravenous access, my priority is to relieve pain quickly while ensuring safety and maintaining the ability to escalate care. I begin by assessing the patient's pain, neurovascular status of the affected limb, allergies, comorbidities, and vital signs. At the same time, I reassure the patient and explain what I am doing, as anxiety can significantly worsen the perception of pain. In an emergency department setting, I manage a patient with a displaced ankle fracture who rated their pain as 10 out of 10 and was distressed and tachycardic. As floor access was not immediately available due to collapse of peripheral veins, I focused on rapid alternative analgesia. I immobilized the limb in a temporary splint and elevated it, which provided some immediate reduction in pain. I applied ice and ensured correct alignment to minimize further tissue damage. For medication, I administered intranasal opioid analgesia, which provides fast onset pain relief without the need for floor access. This was followed by oral paracetamol as a baseline analgesic, provided there were no contraindications. I closely monitored the patient's respiratory rate, oxygen saturation, and level of consciousness after administration. In parallel, I arranged for skilled assistants to obtain floor access using ultrasound guidance so that analgesia could be escalated if required. Once floor access was established, I supported the administration of titrated intravenous opioids under medical direction and prepared for procedural analgesia for fracture reduction. Throughout this process, I reassessed pain regularly and documented both the patient's response and any side effects. The patient's pain reduced significantly within minutes of intranasal medication, allowing them to remain calm and cooperative for further treatment. This approach ensures that pain is managed promptly and humanely, even when floor access is delayed, while maintaining patient safety and readiness for definitive care.
A patient's vital signs are rapidly deteriorating, e.g., hypotension, tachycardia. What is your immediate action plan, and who do you call for help?
When a patient's vital signs are rapidly deteriorating, my immediate focus is on early recognition, rapid intervention, and timely escalation. I act without delay, as hypotension and tachycardia often indicate impending shock or acute deterioration. I begin by staying with a patient and initiating a rapid reassessment, starting with airway, breathing, and circulation. I ensure the airway is patent, apply high-flow oxygen, and position the patient appropriately to support circulation unless contraindicated. I immediately repeat a full set of observations to confirm the trend and assess level of consciousness, urine output, skin perfusion, and capillary refill. In a previous acute medical ward shift, I identified a patient whose blood pressure dropped from 110 systolic to 80 within 30 minutes, with a rising heart rate and increasing confusion. I secured large bore floor access, took urgent blood samples, and commenced a fluid bolus as prescribed, while closely monitoring the patient's response. At the same time, I escalate the situation according to local policy. I activate the rapid response or medical emergency team and directly contact the most senior available clinician, such as the medical registrar or critical care outreach nurse. Clear communication is essential, so I provide a concise handover including the patient's background, recent changes, current observations, and actions already taken. I also delegate tasks to nearby staff, such as preparing emergency drugs, bringing monitoring equipment, or documenting events in real time. While awaiting the team's arrival, I continue continuous monitoring, reassess vital signs every few minutes, and prepare for potential escalation to advanced airway support or transfer to a higher level of care. In the case I managed, early escalation and coordinated team response resulted in prompt treatment of septic shock and transfer to the intensive care unit, where the patient stabilized. This structured and proactive approach ensures patient safety, prevents delays in care, and supports effective multidisciplinary management during clinical deterioration.
Describe a structured handover process, e.g., SBAR or ISBAR, you use when transferring care or escalating a patient to a senior physician.
When transferring care or escalating concerns to a senior physician, I use a structured handover to ensure critical information is communicated clearly, concisely, and without omission, particularly in high-pressure environments. A consistent format helps prevent misunderstandings and allows the receiving clinician to make rapid, informed decisions. For example, during a night shift on a medical ward, I was caring for an elderly patient who became acutely confused and hypotensive over a short period. Before making the call, I gathered all relevant information, including the patient's diagnosis, recent observations, medication chart, fluid balance, and any escalation plans. This preparation allowed me to deliver a focused and confident handover. I began by clearly identifying myself, my role, the ward, and the patient, followed by a brief statement of the immediate concern, emphasizing the urgency of the situation. I then outlined the relevant clinical background, including the reason for admission, comorbidities, and any recent procedures or changes in treatment. This was followed by objective findings such as vital sign trends, urine output, blood results, and changes in neurological status. I avoided unnecessary detail and focused on what had changed and why I was concerned. I then explained what actions had already been taken, such as administering oxygen, securing intravenous access, initiating fluids, or sending urgent bloods, and how the patient had responded. Finally, I clearly stated what I was requesting, whether it was an urgent review at the bedside, specific investigations, or escalation to critical care. Using this structured approach has consistently resulted in timely reviews and appropriate interventions. In this case, the registrar attended promptly, treatment was escalated, and the patient was transferred to a higher level of care. A clear, organized handover supports patient safety and effective multidisciplinary communication.
Describe a time you had a clinical disagreement with a colleague or physician. How did you handle the situation professionally?
I recall a situation on a busy surgical ward where I had a professional disagreement with a junior physician regarding a patient's postoperative management. The patient was 2 days post-abdominal surgery and had begun showing early signs of deterioration, including a rising heart rate, reduced urine output, and increasing abdominal pain. When I raised my concerns, the initial response was that these changes were expected postoperatively and that we should continue to observe. I felt strongly that the changes were not in keeping with the patient's previous recovery pattern, so I approached the situation calmly and respectfully. I ensured I had objective evidence before escalating further. I reviewed the observation chart, fluid balance, and blood results, noting a downward trend in blood pressure over 6 hours and a rising lactate level. I then requested a private conversation with a physician where I clearly explained my concerns, focusing on the patient's clinical signs rather than personal opinion. I explained that my worry was the possibility of early sepsis or internal bleeding and suggested specific actions, including repeating bloods, reviewing the wound, and considering imaging. I remained open to their perspective and listened carefully to their reasoning, which helped keep the discussion professional and collaborative rather than confrontational. Although the physician was initially hesitant, they agreed to reassess the patient at the bedside. Following the review, further investigations were ordered, which revealed a postoperative complication requiring urgent intervention. The patient was transferred to a higher level of care and managed appropriately, preventing further deterioration. Afterwards, I reflected on the interaction and later discussed it informally with a colleague to maintain a positive working relationship. This experience reinforced for me that respectful communication, preparation, and patient advocacy are essential when disagreements arise. By staying focused on patient safety, using clinical evidence, and maintaining professionalism, I was able to address the disagreement effectively while preserving teamwork and mutual respect.
How do you manage highly anxious, distressed, or aggressive family members in a busy department?
In a busy clinical department, I manage highly anxious, distressed, or aggressive family members by balancing empathy, clear communication, and safety while keeping the patient's care at the center of the interaction. I first assess the level of distress and potential risk, ensuring the environment is safe for staff, patients, and visitors. I approach calmly, maintain an open posture, and introduce myself clearly, as this often helps reduce immediate tension. I recall a situation in the emergency department where a family member became verbally aggressive while waiting for updates about a critically unwell patient. The department was extremely busy, and delays were unavoidable, which had increased their frustration. I moved the conversation to a quieter area where possible, acknowledged their fear and frustration, and reassured them that their concerns were being taken seriously. I avoided interrupting, allowing them time to express their emotions, which helped de-escalate the situation. Once they felt heard, I provided clear, honest information using simple language, explaining what was happening, what had already been done, and what the next steps were. I avoided making promises I could not keep and was transparent about waiting times. I also set professional boundaries, calmly explaining what behavior was acceptable and that aggressive language would not help the situation. Throughout, I remained respectful and non-judgmental. In this case, I involved the nurse in charge and, when appropriate, the medical team, so the family received consistent information. The situation de-escalated, and the family member later apologized for their behavior and thanked the team for the care provided. This approach allows me to manage challenging interactions effectively, maintain safety, and support families through highly stressful situations, even during peak workloads.
The department is overwhelmed, and you are short-staffed. How do you delegate tasks and prioritize your time effectively?
When the department is overwhelmed and short-staffed, I focus on structured prioritization, clear delegation, and maintaining patient safety above all else. I start by quickly identifying the most unwell patients using observation trends, early warning scores, and clinical judgment, as these patients require immediate attention and close monitoring. Tasks are then prioritized based on urgency rather than routine, with time-sensitive interventions such as airway support, sepsis management, pain control, and medication administration taking precedence. During a particularly challenging shift in the emergency department, we were short 2 nurses while managing multiple high-acuity patients. I took a leadership role by coordinating with a nurse in charge to clarify roles and redistribute workloads. I delegated tasks based on each team member's scope of practice and experience, asking healthcare assistants to manage vital signs, patient comfort, and basic care, while registered nurses focused on assessments, medications, and escalations. I ensured instructions were clear and specific, including timeframes, to avoid confusion or duplication of work. I also used brief, focused check-ins to reassess priorities as the situation evolved. When possible, I clustered care activities to reduce interruptions and improve efficiency, such as administering medications while completing assessments and documentation together. Communication was key, so I kept the team informed about changes in patient status and encouraged staff to speak up early if they were struggling or concerned about safety. Despite the pressures, we maintained safe care, avoided missed observations, and ensured timely escalation for deteriorating patients. This experience reinforced the importance of calm leadership, adaptability, and teamwork in managing high-pressure situations, allowing the department to function effectively even with limited resources.
Explain the process of obtaining informed consent in an emergency setting, particularly if the patient has altered consciousness.
In an emergency setting, obtaining informed consent requires balancing respect for patient autonomy with the need to act quickly in the patient's best interests. I start by assessing the patient's capacity, which includes their ability to understand the information provided, retain it, weigh the risks and benefits, and communicate a decision. If the patient is conscious and has capacity, even under time pressure, I explain the proposed intervention in clear, simple terms, outlining why it is needed, the main risks, and what may happen if treatment is delayed. I also check understanding and give the patient an opportunity to ask questions, documenting the discussion carefully. However, emergencies often involve patients with altered consciousness due to head injury, sepsis, shock, or intoxication. In these situations, if the patient lacks capacity and immediate treatment is required to prevent serious harm or death, care proceeds under the principle of acting in the patient's best interests. I ensure this decision is proportionate and limited to what is necessary at that time. I promptly involve senior clinicians and follow local and legal frameworks, ensuring all actions are clearly documented, including the reason consent could not be obtained. I recall a trauma case involving a patient brought in after a road traffic collision who was confused, hypotensive, and deteriorating rapidly. The patient could not understand or engage in conversation, and there was no family present initially. The team proceeded with urgent imaging for access, blood transfusion preparation, and surgical referral to stabilize the patient. I documented the patient's lack of capacity, the urgency of the situation, and the rationale for treatment. When the family arrived later, they were informed sensitively about what had been done and why. If a legal proxy, next of kin, or advance directive is available and time allows, I involve them in discussions. Throughout, I act with transparency, respect, and careful documentation. This approach ensures ethical, lawful care while prioritizing patient safety in high-pressure emergency situations.
You overhear a colleague discussing a patient's confidential details in a public area. How do you address this?
If I overheard a colleague discussing a patient's confidential information in a public area, I would address it promptly but professionally, with the aim of protecting the patient's privacy rather than assigning blame. My first consideration would be the immediacy of the risk. If members of the public were within hearing distance, I would intervene straight away by calmly reminding the colleague that we are in a public space and suggesting we move the conversation to a private area. I would keep my tone neutral and respectful to avoid embarrassment or confrontation. I recall a similar situation on a busy ward where a staff member was discussing a patient's diagnosis near the nurse's station while visitors were present. I quietly interrupted and suggested we continue the discussion in the staff room. Once we were in a private setting, I explained my concern, emphasizing the importance of confidentiality and the potential impact on patient trust and professional accountability. I focused on the behavior rather than the person and referenced our professional duty to maintain privacy at all times. If the colleague acknowledged the issue, I would treat it as a learning opportunity and encourage greater awareness of surroundings during future conversations. However, if the behavior continued or if the breach was serious, I would escalate the concern to the nurse in charge or follow the organization's incident reporting and governance procedures. This ensures the issue is addressed appropriately and prevents recurrence. By handling the situation discreetly and constructively, I help maintain a culture of respect and professionalism while safeguarding patient confidentiality. Taking timely action reinforces ethical practice and protects both patients and staff within the healthcare environment.
Describe a time you made a clinical mistake or witnessed a mistake. What was the outcome, and what did you learn?
Early in my practice on a busy medical ward, I was involved in a situation where a medication error was narrowly avoided, and it became a significant learning experience for me. A patient with multiple comorbidities was prescribed an intravenous antibiotic with a weight-based dose. During preparation, I realized that the dose documented on the drug chart did not align with a patient's recorded weight and renal function. Initially, I had trusted the chart without question, as the ward was understaffed and time pressures were high. Before administering the medication, I paused to recheck the prescription against the patient's notes and recent blood results. I identified that the dose would have been too high and could have caused harm. I immediately withheld the medication and contacted the prescribing physician to clarify the order. After review, the prescription was amended, and the correct dose was administered safely later that shift. Although no harm came to the patient, I recognized that the situation could have had serious consequences if I had not taken the extra time to double-check. I completed an incident report to ensure transparency and to support learning within the team. The issue was later discussed during a ward safety meeting, highlighting how workload pressures and assumptions can contribute to errors. This experience reinforced the importance of maintaining vigilance, even during busy shifts, and not allowing time pressure to override safe practice. It also taught me the value of speaking up and using reporting systems as tools for improvement rather than blame. Since then, I have been more deliberate about checking high-risk medications, encouraging colleagues to do the same, and promoting a culture where patient safety is prioritized over speed.
How do you approach providing compassionate care and support to both the patient and family during unexpected end-of-life care in A&E?
Providing compassionate care during unexpected end-of-life situations in A&E requires sensitivity, clear communication, and a calm presence, even in a fast-paced and emotionally charged environment. My approach begins with recognizing the suddenness of the situation and the shock this can cause for both the patient and their family. I ensure the patient is treated with dignity at all times, maintaining comfort through effective symptom control, gentle positioning, and a quiet, respectful environment wherever possible. I recall a case involving an elderly patient who arrived following a sudden collapse and deteriorated rapidly despite resuscitative efforts. Once it became clear that further intervention was not in the patient's best interests, I supported the senior clinician in transitioning to end-of-life care. I stayed with the patient, providing reassurance through touch and calm communication, even when they were minimally responsive, as I believe comfort and presence remain meaningful. For the family, I prioritize honest and compassionate communication. I escort them to a private area and explain the situation in clear, simple language, avoiding medical jargon. I allow time for silence, questions, and emotional expression, recognizing that grief responses vary. During this time, I remain present rather than rushed, despite the pressures of the department. I also advocate for practical needs, such as offering seating, tissues, and access to spiritual or cultural support where appropriate. In this situation, I helped facilitate time at the bedside and supported the family through the initial stages of bereavement until further support arrived. Although the outcome was not what anyone hoped for, the family later expressed gratitude for the compassion and clarity provided during an incredibly difficult moment. This experience reinforced for me that compassionate end-of-life care is as much about presence, respect, and communication as it is about clinical skill, even in the challenging environment of A&E.
Why do you want to work in this specific A&E department, and what strengths do you bring to the team?
I want to work in this A&E department because it has a strong reputation for delivering high-quality, patient-centered emergency care while maintaining a supportive and well-structured multidisciplinary team. I am particularly drawn to the department's commitment to evidence-based practice, early escalation of deteriorating patients, and ongoing staff development. From my understanding, this department manages a wide range of high-acuity cases, which aligns well with my experience and my desire to continue developing my clinical judgment and emergency skills in a challenging but supportive environment. Through my work in emergency and acute care settings, I have developed the ability to remain calm, organized, and focused under pressure. I am comfortable managing multiple priorities, reassessing patients as their condition changes, and escalating concerns promptly using clear and structured communication. I bring strong assessment skills, particularly in recognizing early signs of deterioration, sepsis, and shock, and I am confident in initiating immediate interventions while coordinating with a wider team. I also value teamwork and reliability. Colleagues have described me as approachable and supportive, especially during busy shifts. I am proactive in offering help, sharing workload, and supporting junior staff, while also knowing when to seek guidance from senior colleagues. In previous roles, I have contributed to maintaining safety and flow during peak periods by communicating effectively and adapting quickly to changing demands. Most importantly, I bring a strong commitment to compassionate, respectful care for patients and families, even in high-pressure situations. I believe this combination of clinical competence, teamwork, and empathy would allow me to contribute positively to this A&E department and grow as a nurse within the team.
Emergency nursing is high stress. What strategies do you use to cope with high-pressure, emotionally draining shifts?
In emergency nursing, I have learned that high-pressure, emotionally draining shifts are inevitable, and coping effectively requires a combination of preparation, resilience, and reflection. On particularly busy nights, such as when our department was managing a multi-vehicle accident with over a dozen casualties, I prioritized organizing tasks and triaging patients efficiently while maintaining clear communication with the team. I focus on maintaining a calm and methodical approach to each situation, reminding myself that staying composed directly impacts patient safety and team performance. I also use brief moments between tasks to regroup mentally, taking deep breaths or practicing quick mindfulness techniques to reduce stress levels. I make it a priority to debrief with colleagues after particularly intense cases, sharing experiences and insights. For example, after a pediatric resuscitation, I facilitated a discussion about what went well and what could be improved, which helped me process emotions and reinforce learning points. Maintaining a healthy work-life balance outside the hospital is also essential. I schedule regular exercise, maintain social connections, and engage in hobbies to recharge mentally and physically. Additionally, I proactively develop emotional resilience through training and reflective practice. By keeping a reflective journal of challenging cases, I can track patterns, identify triggers, and develop strategies to respond more effectively in future situations. Over time, I have noticed that these strategies not only help me cope with stress but also enhance my capacity for empathy, decision-making, and teamwork during high-pressure shifts. Ultimately, the combination of structured coping mechanisms, reflection, and supportive teamwork ensures that I can sustain performance and deliver safe, compassionate care even in the most demanding circumstances.
What is one area of A&E nursing you feel you need to develop further, and how will you address it?
One area I have identified for further development in A&E nursing is advanced airway management in critically unwell patients. While I am confident in basic airway procedures, I recognize that in high-acuity situations, such as multi-trauma presentations or severe respiratory distress, advanced skills like rapid sequence intubation and the use of specialized airway devices can significantly impact patient outcomes. To address this, I have taken a structured approach. I recently enrolled in an advanced airway management course, which includes simulation-based training for scenarios like cardiac arrest with difficult airways and pediatric respiratory emergencies. During the course, I practiced decision-making under time pressure, equipment selection, and collaborative teamwork, which highlighted areas where I could refine both technical and non-technical skills. I also actively seek opportunities in my current department to observe and assist senior colleagues during complex airway interventions. For instance, during a particularly challenging case of a patient presenting with anaphylaxis and airway compromise, I supported the senior nurse in preparing equipment and monitoring vital signs. This experience reinforced the importance of anticipation, rapid preparation, and clear communication under pressure. Beyond technical skills, I'm focusing on integrating reflective practice into my development. After each exposure to advanced airway scenarios, I evaluate my response, identify strengths and weaknesses, and discuss improvement strategies with mentors. Additionally, I plan to attend regular departmental skills updates and simulation sessions to maintain competency and confidence. By combining formal training, hands-on experience, and reflective practice, I aim to build proficiency in advanced airway management while maintaining safe and efficient patient care. This ongoing development not only strengthens my clinical capability, but also enhances my ability to support colleagues and contribute confidently to high-acuity situations in the A&E setting.
What does being an excellent emergency nurse mean to you?
Being an excellent emergency nurse, to me, means delivering care that is not only clinically competent but also compassionate, adaptive, and efficient under pressure. In the fast-paced A&E environment, patients arrive with a wide range of urgent needs, from minor injuries to life-threatening emergencies, and each situation demands rapid assessment, decisive action, and clear communication. For example, I once cared for a patient with severe sepsis who presented with hypotension and confusion. Recognizing the urgency, I coordinated closely with a multidisciplinary team to ensure timely fluid resuscitation, blood cultures, and antibiotic administration while keeping the patient and their family informed and reassured. This experience highlighted that excellence involves both technical proficiency and the ability to provide emotional support in high-stress situations. Excellence also requires prioritization and adaptability. On nights when the department was overwhelmed with multiple trauma cases, I had to constantly reassess patient acuity, delegate tasks effectively, and maintain situational awareness, ensuring no patient's care was compromised. I believe that being proactive, anticipating potential complications, preparing equipment in advance, and maintaining a calm presence helps prevent errors and improves outcomes. Additionally, an excellent emergency nurse embraces continuous learning. I actively engage in training sessions, simulation exercises, and reflective practice, seeking feedback from colleagues and mentors. This commitment allows me to refine my clinical judgment, enhance teamwork, and stay updated on best practices. Finally, being an excellent emergency nurse is about resilience and professional integrity. It involves managing the emotional demands of the role while maintaining empathy and advocacy for patients. By combining clinical expertise, effective communication, teamwork, and reflective growth, I strive to provide the highest standard of care, ensuring that every patient receives timely, safe, and compassionate treatment, even in the most challenging circumstances.
Describe a recent change or development in emergency medicine or nursing practice that you have incorporated into your own work.
A recent development in emergency medicine that I have actively incorporated into my practice is the implementation of point-of-care ultrasound, POCUS, for rapid assessment of critically ill patients. This tool has increasingly become standard in A&E for identifying conditions such as internal bleeding, cardiac tamponade, or pneumothorax, allowing faster diagnosis and treatment decisions. Recognizing its impact on patient outcomes, I took the initiative to complete a focused ultrasound training course and began integrating it into my clinical practice under supervision. One instance that highlighted its value involved a patient who presented after a high-speed road traffic collision with hypotension and abdominal pain. Using POCUS, I was able to assist the team in rapidly identifying free fluid in the abdomen, which prompted immediate activation of surgical support. The patient received definitive care within a critical window, and the timely intervention likely contributed to a favorable outcome. This experience reinforced the importance of combining traditional assessment skills with emerging technology to improve diagnostic accuracy. In addition to technical application, I ensured the integration of POCUS into workflow was systematic. I collaborated with colleagues to establish protocols for when and how to use the device, ensuring that it complemented existing assessment methods rather than creating delays. I also participate in regular skill refreshers and case discussions to refine interpretation and decision-making skills, recognizing that competency requires ongoing practice and feedback. By embracing this development, I have enhanced my ability to contribute effectively to rapid decision-making in high-pressure situations. It has improved patient care, strengthened team confidence in clinical assessments, and encouraged a culture of continuous learning. Incorporating POCUS demonstrates how staying current with advancements in emergency nursing practice can translate directly into safer, more efficient, and more responsive care for patients in critical situations.
What elements are crucial for a safe and effective discharge plan for a complex patient, e.g., elderly polytrauma, leaving the A&E?
A safe and effective discharge plan for a complex patient leaving A&E requires a holistic, multidisciplinary approach that addresses both immediate medical needs and longer-term care requirements. For instance, I recently cared for an elderly patient with multiple fractures following a fall, who also had comorbidities including diabetes and mild cognitive impairment. In such cases, the discharge plan must be carefully coordinated to prevent readmission, ensure continuity of care, and support the patient's independence as much as possible. First, a comprehensive assessment is essential. I collaborated with the attending physician, physiotherapist, occupational therapist, and social worker to evaluate the patient's physical status, mobility limitations, and home environment. This allowed us to identify potential hazards, necessary assistive devices, and required support services, such as home nursing visits or community rehabilitation programs. Medication reconciliation was another critical element. I reviewed all prescriptions with the pharmacy team, ensuring clarity in dosing schedules and checking for interactions or contraindications. Equally important is patient and family education. I provided clear instructions on wound care, pain management, and warning signs that should prompt a return to the hospital. I also involved the patient's family in practical aspects of care, such as safe transfer techniques and daily monitoring, emphasizing their role in supporting recovery. Clear documentation and communication with the primary care team were ensured so that follow-up appointments, lab tests, and specialist referrals were coordinated effectively. Finally, ongoing monitoring and accessibility are crucial. I ensured the patient and family had emergency contact numbers and guidance on who to approach if complications arose. By combining multidisciplinary collaboration, thorough assessment, patient and family education, and robust follow-up, the discharge plan became a structured, safe, and patient-centered pathway that minimized risks and promoted optimal recovery.